We are live now. Hello.
Yes, sir, you are live now.
Okay. So, good evening, everyone. And I welcome you all to this first DOS global webinar. This is the first episode that is on the rafting in the rapids. And we have the most distinguished faculty with us, those who all have a very vast experience in cataract and refractive surgery. So today's theme is we'll be presenting our videos and or the situation, a most difficult situation of our clinical practice, and how quickly and how nicely we manage these cases in our practice. And I hope this session is going to be very enriching academically and enjoyable to all of us. So without much ado, I'll request our secretary, Dr. Bhalla, to proceed with the proceedings.
Yeah. Thank you, Dr. Rajendra Prasad, sir. I think this is one innovative beginning. We are going to the start of our current calendar of academic year of DOS. And we are starting, we have had our monthly meeting, inaugural monthly meeting on Sunday. And this is the new thing, the global web series. And it has been aptly titled Rafting in Rapids, as Dr. Rajendra Prasad said, that this is a video-based session which is based on the management of most difficult case scenarios by panelists, expert speakers of which we have the particular expert has encountered during his cataract surgery. I welcome all the esteemed speakers and also the DOS executive, which have supported this wonderful idea. I also welcome all the delegates who are attending this, and I'll request our moderators to take over and start the proceedings from here.
Thank you so much.
Dr. O.P. Anand, please.
Good evening, sir. Thank you so much. I'm Dr. Jatinder Bali, and my co-moderator is Dr. O.P. Anand. We will start with the introductory video of our We picked up the topmost operatives from across the world, the most daring operatives, and we asked them just one question, one single question. And that was, what was your most difficult case? Over to you, Dr. Anand.
Thank you, Dr. Bali. It is a well-awaited webinar. It's my privilege to introduce my first speaker. It's none other than Dr. Professor J.S. Titial. As you know, he's an international figure in the field of ophthalmology. He's awarded Padam Shri by President of India in 2014. He has many distinguished awards to his credits, 2 patents, 4 gold medals, more than 400 publications, more than 3,500 citations, 6 books, and more than 60 chapters. An unending academic achievement to Professor Titial. We are lucky to have him with us. He remained president of Indian Society of Cornea and Keratorefractive Surgeons in 2016. He remained chairman, National Eye Bank. He remained president of our beloved Delhi Ophthalmic Society. He remains secretary as well. So what to say, Dr. Titial is the teacher of teachers, and we are lucky to have him today. And we'll learn some tips and technique to handle the difficulties in complete cataract surgeries. My request to Dr. Professor J.S. Titial to please start his deliberation, sir. Dr. Titial, sir.
Okay, somebody has to unshare, no? Yeah. Thank you. Okay. I hope it's visible.
Yes, sir.
Yes, sir. Yes, sir, it is.
Yeah,
It's
thank you.
visible, sir.
Thank
Please
you,
go on.
President Dr. Rajendra Prasad, Secretary Dr. Balla, and the entire executive and the two young moderators, Dr. Anand and Dr. Bali. It is my pleasure to start this fresh session of DOS, the global series of webinars. And today I'm going to show one difficult situation of doing a cataract surgery with the help of a 3D headset device. We all understand sometimes the situation is not actually the eye, it is the body, which makes things very difficult for all surgeons. And this is the scenario where you have deformity in the spine, which doesn't allow a patient to lie flat, which is a requisite for doing a comfortable phacoemulsification or a cataract surgery in most patients. So this can be a patient with a spine deformity like kyphosis, scoliosis, or the orthopnea, mineral disease, or CNS abnormalities. And these cases are most of the time denied surgery by many people because very difficult positioning for these patients. And these patients end up with very advanced cataract, and sometimes the surgery becomes very challenging for these patients. Few of the recommended position for handling a difficult positions, people have done face-to-face or a stream Trendelenburg position, like you can see in the second picture, or sometimes surgeons do a standing surgery for these patients. So all these have a difficult scenario for a patient and surgeon both. Face-to-face is difficult to understand. You have to operate for inferior side. Stream Trendelenburg position makes the uncomfortable foot positioning for a surgeon, and the eye level and phaco machine level doesn't match. The things become very difficult. And we all understand standing phaco can be much more difficult for most people. So let me take you through this challenging case of mine. And the old gentleman, 85-old person with hypermature senile cataract there for a very long time. And other eye also had a significant cataract with very poor vision in both eyes. He had a fixed cervical kyphosis. You can see almost 90-degree position from his chest. And it was very difficult to make him look flat in any position on an operating table. So this is what we normally appreciate. You should have a right angle position for a microscope and patient's eye. And surgeon arm also should be at 90 degrees so that you become comfortable doing a surgery with better ergonomics of a neck back state for surgeon. And this is my patient who was absolutely 180-degree position apart from 90-degree, which normally we see. So this is a challenging situation which we have to face. And this is what I realized the advantage of heads-up device where you don't have to see the ocular, which will be having a totally different outlook as such. So I'm taking through the video of this patient. You can see I've slanted the patient almost 70 degrees, and his neck was fixed. It did, despite putting multiple support system, the head could not touch the this area, and he was quite a stable this. And see the distance from microscope focus to his eye was so difficult, and there was the advantage of a heads-up device for this patient. So this is a scenario which sometimes do face in once in a year, the operation theater, a patient comes. You can see that the increased angle between the microscope tube and eye plane. This is a microscope plane, and this is a patient eye. And somebody had to hold his pillow cover and head so that it doesn't fall downwards. And I've seen patient being tied up in a table also so that he remains stable. So this is a situation, the eye was totally slanted, almost 40-degree slant from the orbital rim. And my operating table was such a place which could have been difficult to see through the oculars here. So this is a surgery I'm doing with a comfortable position for surgeon with my hand position almost 90-degree as it could be for normal surgery. Though my left hand was little difficult, it had to slant absolutely vertically down, and the chopping maneuver would have been difficult. But my eye position was absolutely parallel to the screen which was there, and that made us life easier. You can see I'm seeing parallel to the plane, and surgery becomes much simpler, which would have been very difficult and challenging seeing through the operating microscope ocular I'm pretty sure I would have been doing a standing surgery and your hand-eye coordination becomes very difficult. So this is the microscope view. I could do a rhexis by putting my hand inferiorly, which is so difficult to maneuver. And because of hypermaturity, it was so difficult to do hydrodissection also. So it was a rock hard cataract. I was doing a little bit of trenching, which went up to like a crater. Subsequently, I could do a chop. So seeing through the screen with polarized glasses, the depth perception are better. The magnification I could improve. Subsequently, I could chop the nucleus into halves. At this stage, you can see the eye is totally slanting towards the chest. And your second eye hand coordination can be very difficult for routine people. So this is the completion of one of the area for chopping. Then I'm trying to complete chop from the periphery here. And you have to be very slow because your distance of handpiece will be unequal, inferior to superior. If you are doing superior emulsification, you are much nearer to the corneal endothelium and things very difficult. So I had to vertically slant the nucleus piece and try to do phaco in a comfortable position. Towards the end, I realized my phaco handpiece was very near to the posterior capsule. So I did inject viscoelastic to maintain the bag, injected IOL as a scaffold for a subsequent completion of a phaco. I think this is the very important technique which Dr. Amar had devised for a PCR, but this can be used for a difficult emulsification also. I could do a completion of phaco in such cases and doing a bimanual aspiration. And this completes a surgery in a very difficult slanting eye, which is absolutely more than 70 degrees slant. You can see the appreciation of slant here. And to do surgery in a slanting eye would be very difficult. As I said, the position inferior to superior would be so different in terms of depth wise also. So this is what I thought I should show. Sometimes you do have advantage of a 3D heads-up device. It gave me the enhanced ergonomics for surgeons seated comfortably and doing the comfortable position phaco in these cases. Focusing was better because I had to focus on the screen and the patient eye level did not hamper my foot positioning, other thing, because I could put a proper positioning with this patient. And better magnification which also is important. Not only the central area, I could see the peripheral magnification was also better. The slanting eye microscope view would have been totally difficult and you would be struggling to focus every time in such case. And subsequently, you can see the depth also was better appreciated with it. So I can understand having advantage of this microscope with us and I could do surgery comfortable for this patient. Thank you for kind listening and giving this opportunity.
Thank you, sir. It's really a great cataract surgery we are lucky to see because this kind of very advanced system are not available everywhere. So your institute is unique in that. But definitely I have seen that patient who's having neck deformity and their neck cannot be manipulated. There is definitely a visualization problem. So anyway, you have to adjust yourself, but this kind of neck rigidity what you are operating is definitely impossible, and the normal set of people cannot do it, sir.
It was like a 90-degree patient was like this,
Yeah.
And I was operating like this.
Yes.
It was so difficult,
So we always talk to
luckily,
the fundal glow and everything, sir. In this case, I mean, you forget each and everything.
Yeah.
So the way, sir, you chop the nucleus, I was really scared. How you control your foot pedal and the phaco energy that you are going such a odd places that anytime the PC can come in contact.
Yeah, that is
great.
true. That's why
Great.
towards the end, I came out and injected viscoelastic because that would have been very difficult towards the end.
Last piece is always, sir, invite the phaco, the PC near to the phaco and you just protect it with the. So that is a great tip, sir. Definitely. So somebody is landing in this problem can use this scaffold technique just to protect the last stage phaco, the PC tier. Thank you so much, sir. It's really nice.
Thank you.
So going forwards, do you really foresee the improved ergonomics making this system more popular amongst surgeons for other cases other than this one?
Dr. Bali, you rightly pointed out, I think future is, this type of device, which has the better magnification. You can magnify the entire visibility. of patients, and it gives you a better depth perception also. And you
Especially
can
the peripheral
you
angles.
can magnify without distorting the image, which is not possible under the microscope. And the people who are seeing the surgery also had an advantage. It's a very good teaching tool, as well as
Definitely,
for
sir.
surgeons also. If you take me,
Definitely.
I've been doing this surgery for now more than 2 years. I do almost 100% surgery in this headset device. For me to get back to oculars is very difficult. I have a difficulty seeing through the oculars now because everything looks very small. So
Okay.
this
So
is the
how
future.
how happy are the assistants?
No. Some assistants have a difficulty because if you are doing a single table surgery, the assistants are comfortable. I do a side-by-side tables. So sometimes the assistants have a difficulty because they are also using the polarized glasses. So their distance is much more than mine. More the distance, you have a more the 3D effect. So distance, if I keep my distance around 1 meter, and that gives a very comfortable, I think, assessment of your case. If you keep slightly longer, some people keep at 1.5, 2 meter distance, then the 3D effect is too much. So surgery can be difficult sometimes.
Thank you so much, sir.
So do
Any
you,
other
Dr.
panelist has
Kityal,
any
Dr.
observations?
Kityal, do you find any lag between the steps? Any lag? Because this is one of
Yeah,
the important points which
yeah.
has been raised many times.
I think very good question, Dr. Rajendra Prasad. When the initial device came through Alcon, and they did have the lag because that was not meant for actually the anterior segment surgery. With the Artibo 800 from JICE, we have an anterior segment module. There's no lag at all. It's like a surgery in a normal way. So that's the advantage of this system.
That's good.
Because of the presence of lag would might make the things difficult, like PCR has occurred and you detect it slightly later and it increases. Said the present generation.
It's not there now. It's not at all.
Yeah, it is not there.
Because it's like doing a normal surgery. But as I said, there's a trick also. If you keep a distance more than 1.5 meters, then your actual manipulation becomes difficult because it gives you too much of 3D effect. If it is slightly nearer, so it is a comfortable distance, and every step becomes very simple and effective.
Right.
So some of the high volume surgeons have been saying that it slows down the speed of their surgery. Is it true?
Not at all. Not at all.
Yes, no.
Great.
It is
That's
same. In fact, I do faster than routine surgery once you get used to this system.
Very right. Very right. Okay. Thank you, sir. Thank you very much.
Thank you so much, sir.
Thank you. Yeah.
So could we go on to the next speaker, sir? Mr. President, sir, Dr. RP, sir.
Yeah.
Yeah, I think.
All right. So coming up. So after that wonderful exposition of ingenuity, we have with us the second daring operative, Dr. Bharti. Dr. Sudhank Bharti from the Bharti Eye Foundation has been in practice since 1985 in Delhi. He specializes in refractive cataract cornea surgeries. He has been an international investigator for NIDEC, and he has over 50 original papers presented at the American, the European Society, the Asia Pacific, the Korean societies, and at the DOS. He has been the president of the Delhi Ophthalmology Society, the IIRSI. He's been the treasurer of the IIRSI, the secretary, and he has been a pioneer in adopting and adapting to technology. But today we want to ask him another question. We just want to know what was his most dangerous, difficult mission. Dr. Bharti, please, sir.
Thank you, Dr. Bali. I'll start my video. And this is what I have to show for the floppy iris. 3-point formula for success. The author has no financial interest.
Yes.
This patient came with this iris chaffing created by the previous surgeon. where he could not even start the surgery because of the iris getting out of the main port. So when I started, I wanted to start the port at another point and made the side port and released the synechia. And created a rhexis from another side port with a cystotome created with a 26 gauge needle. The rhexis was achieved comfortably under a normal viscoelastic. Main port was structured and hydro procedures were performed. And you can see the iris has already started prolapsing from the main port. But without doing much, I started with the nucleus management with phacoemulsification. And I realized that iris has started prolapsing from both the side ports. I tried to go ahead, but pupil is coming down continuously. And iris prolapse from the side ports is increasing, creating a situation where it is difficult to continue. So I had to reposit the iris and use the first tool in my armamentarium, which is intrafemoral phenylephrine. I thought that I'll be able to manage. But and looking at the severity of the iris prolapse, I used the second tool, which is a Malugin ring. I could have used any device for pupil dilation and holding. I preferred Malugin ring because it does not need multiple ports. Iris was engaged in the Malugin ring without much difficulty. A high density viscoelastic was used and I continued with the phacoemulsification. And despite that, the iris started prolapsing more. So I had to use more viscoelastic to push the iris back. But as you can appreciate, despite all the three things used, there is a little bit of iris prolapse from the side. Finally, the nucleus management was completed and cortex was aspirated, and a 4-loop foldable IOL was implanted. This gives excellent centration of the IOL. Now, to manage the iris coloboma because of the iris chaffing from the main port earlier, I had to put in an iris implant which could take care of the photophobia from this temporal coloboma of the iris, because this could have been very annoying and incapacitating for the patient. This iris implant was fixed in the bag and rotated to cover the coloboma completely. And then Malugin ring was explanted. The three tools to manage floppy iris are intracameral phenylephrine, mechanical pupil dilation, and high density viscoelastic. Thank you.
Thank you, sir. Floppy iris definitely a problem for even the very competent surgeon I have seen. If I remember correctly, the floppy iris flow so fast, even the better than the nucleus pieces. So you try to hold the nucleus piece, you hold the iris first. So this is and it is very, very frustrating for the man. Once you damage the sphincter, then you think that everything has lost. But sir, you manage very nicely, and I think you are putting two implant, the Malugin ring and the NRIDIA implant also tribal inside that require a lot of skill. And
thank you, Dr. Anand.
Thank you, sir. But you manage nicely, sir. I suffer with one of my patient is really give me a lot of sweating. What to do? The iris is flowing like anything, and you have used the ring. I have used the hooks. Even then, whatever the part was left, it was pouring into the phaco probe. So that was really. But you managed very nicely, sir. And sir.
Yeah.
Yes.
You were asking some question, then I'll have my comment.
No, sir, I was just asking that putting a Malugin ring, I just could not dare to put it inside because the iris was so moving here and there that can I put really ring inside? So I just select the iris hook first. But that doesn't solve my purpose.
I think why I did not put the hooks is that you need 4 ports. So the iris will start prolapsing from all the 4 ports rather than prolapsing from 2 only. So I could have managed better. The second thing is that the larger port, you should have one, either the hook or the Malugin rings, holding rings, angles to be just inferior to the main port, so that the iris does not get out or prolapse from that main port. And phenylephrine works only in very mild kind of situations. But if it is a severe floppy iris, then probably it does not work so much. The only thing is that you can put some high density viscoelastic, and you know all those viscoelastics which are there to push the iris back and put it a little bit in the angle so that the iris is pushed back. So those couple of things are very important. And yes, and then you have to be very slow. So the whole thing is, it's a game of patience. I think one has to be very patient in managing this kind of situation, and then you can win.
Sir, any
Okay.
experience of
Can I
the
ask a
available
question, Dr.
intracameral dilators like phenocaine and all? Can they really help in?
But phenocaine is, yes, phenocaine is a good option, but phenocaine has got little bit of phenylephrine. I actually put adrenaline, which is actually phenylephrine, pure adrenaline, without any anesthetic or anything. The only thing I want to use phenocaine is probably when I'm putting a Malugan ring, because when you put a Malugan ring, it is sometimes painful for the patient. So in those cases, I always put, whenever I'm using something, I want to anesthetize the iris completely. But in this particular case, at that point in time, I used phenylephrine pure 100%. So that was the only thing I can, use it at that
I
point.
think
Kokar,
Dr.
you
Kokar
want
wants to make a
Dr.
comment here.
Yeah,
Okay.
yeah, that was a fantastic presentation, Dr. Bharti. Can you hear me?
Yeah. Yeah,
Okay.
we can hear you.
I just wanted to ask two things. I mean, why did you go ahead with the Malugan in the first place? Because once you saw it's all shoved up, and the moment you do hydro, I mean, once you do a Rexis and you do hydro, most of the times it's a giveaway sign. It tells you that please don't put a probe till you're actually got your iris into place.
Yeah.
Because whenever we do hydro, it's always, it comes out and it shows you the shimmering of the iris. And second thing is, I in these patients start atropine 2 days before, ointment per se in the adults also. So all the receptors are saturated. So even if you touch it here and there, it's not going to constrict as much as if you don't use the atropine. And I think I would have gone with the Malugan straight away in this patient. Of course, iris hooks don't have a role in this patient, because it's, if you put 3 iris hooks, it'll still come in between, it'll come to your probe, because it's all floppy. So iris hooks are out of question in this one. So it has to be Malugan. I would have started it straight with the Malugan even before doing my Rexis. So I would have got a little bigger Rexis than what you had actually.
So actually, when the patient came in, it had iris chaffing, but I did not realize that it is going to be like a IFIS. I just thought that the surgeon who did it, and I know the surgeon very well, I thought the surgeon, did it was, kind of not so proficient in phacoemulsification, and that is what I personally thought. So I did not start atropine.
Yeah.
You are right. And the second thing is, when I started, I also did not think that it will be like a IFIS. So that is why this becomes a difficult case if you have not, seen the iris prolapsing at the end. There was no history, or there was no notes that this was because of the IFIS, and the doctor, the earlier surgeon could not go inside, and the iris started prolapsing from immediately after making the main port. So that is the reason, but and I thought that I'll be able to manage that, but that was not to be, in fact. So
I think Dr. Bharti, you have very, very nicely managed this situation, and which you.
So actually,
well.
1 second, actually the history taking becomes very important, Dr. Bharti, in all these cases. Even if you didn't have a history that was being told by the previous surgeon, you could have, because obviously most of these patients would be on tamsulosin. So
no, this patient was not on tamsulosin. One thing is, the patient was not on tamsulosin, and the second thing is that the history was that the patient's wife was operated by the same surgeon, so they were very confident that surgeon, but she could not do much. So that is how, the patient came to me, that she could not do, and I think I want to get it done from you, because the lady is not ready to try it second time. But there was no history of iris prolapsing and all those facts, which I am, very particular that I am asking the history and asking. And actually, to tell you honestly, they are a known family. So the whole thing is that they had so much of thing that okay, I thought that I'll be able to do it. There was something going wrong somewhere with the earlier surgeon, but I never expected that is because of the IFIS primarily. Right. Yeah.
So I will just, when a patient comes to me post dilatation, if you have to see and the patient is mid dilated, first question I ask him, drops kitni baar pade and in the OPD, and are you on any of these? So invariably they have. So what Kokar has said, I agree with him that if you can start with the atropine, it may have some beneficial effect. And the second thing which I will wish to say is that phenocaine, on the contrary, is better than this thing, because phenocaine has both tropicacil, and it has phenocaine, and it has phenylephrine, plus it has lidocaine. So you don't have to really put Oculon separately because it is a cocktail of all three. And in the US that you have, that has ketorolac in it. So actually, we also have a ketorolac or a non-steroidal anti-inflammatory, and I start these patients also on a non-steroidal anti-inflammatory drops. So
that is the routine. That is the routine in all the cases.
Yeah, so Midra, if you have that, the non-steroidal anti-inflammatory that is also injected, that gives you a good outcome. And one more thing which Rohit Om Prakash shows in all of his videos is the side port needs to be planned very well. Because if you see from the side port, once that vicious cycle starts from any of the ports, if the iris keeps on coming, there is going to be a problem. So what he has said is that all the ports should be as small as possible, and they should be just allowing the.
So this side port was not larger than the IA probe. The idea is to make it as much as the IA probe.
No,
So
that
even the incisions, actually, incisions, you have to make little anterior incisions.
Yes.
Whenever you are expecting the iris, floppy iris, and make a little anterior incision, then you won't have the too much of prolapse of the iris through the incisions. So I think it was very well managed, Dr. Bharti. Thank you very much. And I think
Dr. Prasad, can I just, just 2 comments?
Just
Hello.
one.
Yeah. One is that, yes, very rightly, very nicely managed by Dr. Bharti, sir. Yes, as stressed by Dr. Mahipal Sachdev, the calibrated side port which Dr. Rohit Om Prakash always comes up with, and the anterior corneal incision. And 2 points which have been noted is that even if you stop pre-operatively tamsulosin, patient is on.
Doesn't matter.
Doesn't help.
It does not help. And second, we also have to take into account that even females, because they are also given this tamsulosin and aprazosin or bladder neck obstruction. So just gender may not be the only thing that females do not have. So,
so on the contrary, you should not stop tamsulosin because normally at times when you're using atropine, you can push the person into a retention
of urine.
Yes,
so stopping is not helpful. In fact, it may be counterproductive.
Yes.
Thank you. Thank you very much, Dr. OP.
Sir. So, in this webinar, sir, our next speaker is our star speaker. Hello.
Yes. We can hear you. Yeah, Dr. OP.
Yeah. Sir, is our star speaker none other than Dr. Mahipal Sachdev. We all know him very well. Is I should say that one of the best ophthalmic surgeon I've seen. Now he's the medical director of Center of Sight Group of Hospitals, Pan India. He was awarded the prestigious Padma Shri Award by President of India. He holds various prestigious posts like the President of AIUS, the DOS, and IIRSI. He is recognized globally with his fellowship and scholarship. He is pioneer in India with the technique of phacoemulsification and LASIK for removal of glasses. So he remained leader in the new technology in our countries. He conducted and performed several live surgery demonstrations, even in the remotest place of the India. Ensure that the Indian flag remained flying high in the domain of the world of eye care. Really, sir, I welcome you. Please present your deliberation. Thank you so much, sir.
Thank you very much, Dr. O.P. Anand, and thank you very much, DOS, RP, and obviously Jatinder and Dr. Bhalla for giving me this opportunity. Well, I'll be sharing with you yeah, is that visible?
Not, sir.
No, sir.
Not visible as yet, sir.
Just one second. Raghav, can you share it? Raghav?
Yes, Avansan.
Yeah, sorry. I don't know why it's not. Okay, so I'll be showing you a particular case. This patient came to us from, I think, Guwahati, and from Nepal. Actually, this patient has come to us from Nepal. And this patient had a surgery done about a decade ago and had a great lens implanted in the eye. But the patient was complaining of deterioration of vision over the last couple of years. And was also having a problem vis-a-vis scattering and glare. Can you just play it, Raghav?
Yes, I start? Yes, sir.
Yeah. So I'm just going to show you the difficulties that we had. So this is the patient, you can see some amount of capsular phimosis. It's a well-centered lens. You can see that the vision has gone down to 6.9 and you can see the clouding of lens. So there is a lot of glistening in this lens. It's a yellow lens and you can obviously make out the lens though well-centered is one of the problems that we wanted to do the exchange for this particular lens. Raghav, it stopped playing.
So is it playing now?
Yeah.
Yeah.
So you can see we take a blunt spatula. This is the VY rotator. So what we have to do is that in the first instance, we have to at a 360 degrees, just remove all the what was causing the phimosis and the retraction, the capsular contraction was there and the the capsule was stuck onto the intraocular lens. You can see there is some residual cortex also which is there. And 360 degree through using the side port also, we have tried to just free up the capsule. Now, the problem here is going to be that the haptics are going to be pretty well stuck and we are going to have a lot of problems. So we are using a Sinsky hook in this particular case and try to limitate out the intraocular lens. So you can see we get the edge here. There you can see that's the square edge of the lens. The patient didn't have PCO, but you can see glistening very well that you have in this particular case. And what we see here is that we are trying to get one haptic out. So this is causing me problems. So what I do is that I just snip off the haptic because I didn't want too much of pressure there. I make another side cone, taken a capsular hook because there was the mobility of the capsule and it was getting onto a ZD, zonular dialysis that was there. So you can see I'm taking out the haptic which I had slipped off. And now in this particular case, again, we will go off with it's a two-handed sandwich technique that I am doing. So we are just removing the lens and trying to get it out of the bag. Again, there is a problem as you see, a lot of viscoelastic is required. This is the smile forceps that I use. I love to use this because it gives me a good hold. And again, you can see that the second haptic, I slip it off. Unfortunately, this haptic was so adherent that I decided to leave it there, but now I have the full optic which is out. And this is the optic which I have the kind of now slipping it into a half. You can see a lot of cortex has come out, and this is the haptic which we are giving, holding it from below so that the scissor does not injure the capsule, and we will just rotate it out. You can see once you have half of it cut, you can easily take it out. And the capsular hook that has been has been used. You can see it keeps the capsule going on and doing a zonal dialysis as you can see in this particular case. We go ahead and put a 3-piece lens because there is some amount of zonal resistance which happened actually, and now we are trying to push it into the back. The problem is I have just cut it, but I tried several times and the lens did not go because there were still adhesions in the periphery. I'm trying to take out the capsular hook and again put it, but it doesn't work. So what I decide in this particular case is to go ahead and put it in the sulcus. Now the problem here is that it is very well placed in the sulcus because there is a taut anterior capsule. So I have to get rid of this capsular phimosis which was there. And I just make a nick here and kind of take off the capsule from the center. It's going to back. And you can see this is the end of the surgery and the patient, this is a very recent case. So as of now, the patient is doing well post-op. And you can see from this lens that the amount of glistening that is there, with the vacuums which are there. And this is happening recurrently that we are seeing that these patients after several years of implantation are coming back with this glistening. And I can basically my fellows and I can tell from the beginning that well what kind of lens has been put in this particular eyes. You can also have a total whitening of the entire lens, but these glistenings to tell people, Raghav, you can stop sharing. Glistening to you can tell the audience is that these are vacuoles and this has got something to do with the way the lens is, whether it is lathe cut or whether it is the material that is used or whether it is the molding and the amount of water content that is there in the hydrophobic lens. Though the material has now been changed, but still this lens in India is coming with the same material, which I don't know for what reasons are we still getting the old material. But as time is elapsing, there are enough and more cases of glistening that are coming. And we can't really wish this away that the patient does not have any symptoms and all, because it's a slow process and maybe with both the eyes. But if you compare one eye with the lens which is non-glistening and the other one which has glistening, the patient does have scatter, the patient does have night vision problems, the patient has contrast. And in this particular case, the vision, the posterior segment, everything was evaluated. The vision had gone down by 1 line in this particular patient. So we had no option but to remove it. But what I wanted to show you was A, glistening, and second, what I wanted to show you was that how you can handle a small piece of the haptic was left in, it doesn't matter. We tried to handle it. I would have loved to put it in the bag, but since it was difficult, we would not have been able to open up the entire bag because this was almost a decade old. We prefer to put it in the sulcus, and when you are putting it into the sulcus, you have to put in a 3-piece lens and a thick capsular phimosis. You have to really snip it off so that the central visual axis is clear. Thank you.
Sir, thank you very much. It's really a difficult surgery, but I was looking for that at any time you can land up with a severe zonodialysis. I have exchanged few of the lenses, one for the glistening and other for the refractory surprises. But I couldn't enter with this kind of adhesions, but you are really managing. And the trick, what I have understand, sir, the putting of your capsular hook was the great. I mean, that was the things when you just try to mobilize the lens and your bag start mobilizing with that. So the technique of using the capsular hook was the, I think it's of utmost value. I think we can use it in future at such type case we'll end up. So it's a great job, sir. And particularly, I feel that the patient should be taken the consent that in other scenario, we can put the skull fixator lens as well, because, sir.
Yes, you're right. We did take that consent in this particular patient, but the patient was really very, very clear. He had come from Nepal just to get an explant done and a new lens put in.
Right. With a minimum glistening there and there's phimosis, do you think this posterior YAG could have been a better option?
No,
just to
get away with one.
PCO.
The patient didn't have a PCO. The square edge of the lens is fantastic. It doesn't cause PCO. There was some sequestered cortex towards the periphery, but the patient didn't have any PCO.
So it wasn't a complete phimosis syndrome.
That actually, see, that is the problem, Sudarshan. The point is that to an uninitiated person, he would feel that this is PCO or something, and you will do a YAG, and then you are in a big problem that you have a capsule which is not intact, and then trying to take out the lens is going to be very, very difficult.
No, Maipal, I'm not saying about the YAG for the PCO. I'm talking about the YAG for the phimosis syndrome, because the treatment for the phimosis per se could be opening the YAG at the back so that let the fluid go out and whatever is stuck up there.
जो phimosis था ना, कैप्सूल इतना छोटा नहीं था कि 2-3 मिलीमीटर हो गया हो. अगर वो 3 मिलीमीटर हो जाएगा,
that's what I'm saying.
तो मैं करता. ये तो this was about 4.5 to 5.
This was decent enough, yeah.
Yeah, this was decent enough. So I don't think a YAG would have helped by doing this particular thing. It is not really. What I was saying is the difficulty because of the capsular contracture that was happening, but it was still maintained at a decent size, maybe 4.7, 4.8. It wasn't a very small thing to compromise the vision.
Absolutely right. The other thing I just wanted to add was that in case you have a small phimosis and you want to remove the lens, which I think the railway guys should know, that you should actually cut the phimosis before. You can make a small snips in that, make it a little relaxed. Because if you're going to a tight sphincter versus a sphincter which is snipped at multiple places, it'll be easier. And you can apply iris hooks, even not even one, you can put more in case you want the bag to be totally safe. Otherwise, of course, the bag moves. And we have all gone through this one. And of course, once the single piece comes out, 99% chances are that the 3-piece will go in, which I think he wonderfully showed us skillful surgery. So,
this glistening and opacification of the lens is more common with the lenses which are injection molded manufacturing rather than the lathe cut lenses.
Yes. Yes.
And but we have seen, because this is very common with the Alcon lenses, because it's the injection molded lenses. And we still keep putting these lenses, and a lot of cases come with a lot of glistening and opacification. So what do you say about this?
The RP, the biggest problem that I don't, which I can't come to terms is that once they know that this material, whether it is injection molded or whether they've changed the material also from a water content, which was below, I don't know, 0.1, 0.2%, they've increased the water content to about 2% or something like that. And Vista is about 4%, and they are glistening free. I haven't seen this with the J&J lenses also. But the point is, once you know that this material and whatever is the process that is there, why the hell are we still getting the lenses which are with the old material and which are with the same thing? So that is something US has totally given away the old material. Why is it that we are still getting the same, and why are we are still, even the Panoptics I think has the same material and the same thing. So it is not a fantasy of somebody, or if somebody, then all of you would have seen that. Now the point is, if we want to wish it away and push it under the carpet, that's something else. But I think we should use our collective force to say that we should only have the new material lenses which possibly do not have glistening. That should be available to the Indian eyes, Indian ophthalmologists, Indian patients.
Yeah, that's true.
One thing I like to add is all these yellow lenses, the blue blocking lenses, actually the contrast is the glistening is picked up early actually. In fact, lots of patients of the old time when we saw them 1 to 2 glistening, but they're not bothered about the vision, 6 partial. So we leave them alone. But yes, we have
Darshan,
to.
the point is that it is like a cataract growing on people. The point is that they don't. So this is something which is not happening overnight. So the fall in vision, the fall in contrast, the fall in everything is going on very gradually, and it's progress. So patient does not realize what he would have if the patient has a clear lens versus a one with this. So why would I don't know if you would know that you are going to have glistening in your eye. Would you want to have a lens like that in your eye?
Of course not. So once we know that the lens material is not good, the first quality of the lens has to be that it has to be inert and it should not change its characteristic inside the eye. If it's changing its color and becoming cataractous, like we had those HydroView lenses, I think we remember, I put about 10 of them, I removed 11 because I think one came from the other OT. So the thing is, all of them were taken out. So those were filling material actually that time. But now even the phobic.
We keep on seeing these hundreds and hundreds of cases actually, because many cases, because we see in each OPD 2 to 3 cases of these glistening.
I agree with Dr. Mahipal that we should put a foot down in saying that why can't we get the best material which is launched outside? Why should we be getting
have best material
it's
already?
Between the bisulfide bonding which they do and the stain they use. You use the lenses of, say, for example, other company. I've tried Hoya yellow lenses, which are basically violet blocking, not the blue blocking.
Yeah,
and those lenses don't show glistening over the 5-7 years we've been following them up. But the one specific company, it just shows more glistening, and I agree with him fully on that point.
That's right. I think Dr. Mahipal has very nicely managed this very difficult case and shown us the technique, and so beautifully managed. Thank you, Dr. Mahipal. Thank you very much.
Thank you.
Dr. Opi for the next.
Sir. Sir.
And now, after the James Bond of India, we have our international daring operative coming up. It is Dr. Hosam Ziada. He is the Associate Professor of Ophthalmology and the Head of Cornea and Refractive Unit at the Al-Azhar University in Cairo, Egypt. He is, by training, a cornea, cataract, and refractive surgeon, having several international publications and gold medal awards from ISCRIS, IARSI, DOS. He was also awarded the International Hero by the International Society for Manual Small Incision Cataract Surgeons. He is the president of the Egypt chapter of ISMSICS, and he is also the founder of the Ziada Academy for continuing ophthalmic education. Ladies and gentlemen, the world today now wants to know what was his most difficult case. Dr. Hosam.
Yes, hello, Dr. Bali. How are you? Thank you so much. And I'd like first to thank you all and I'm a grateful thanking for my dear friend, Dr. Prasad, for his kind invitation for this amazing meeting. Also, my greetings to you, Dr. Bali, and all my dear friends, Dr. Prasad, Rajendra, Dr. Mahipal, and all of my dear colleagues. So let's go to the most difficult case which I have faced during my phacolist. So I will share my screen now.
Yeah, please do.
Yeah, okay. It's visible.
Yeah.
Yes, it is.
Yeah, it's visible
Can you
now.
go into full screen mode, please?
Yes, okay. Now it's okay.
Yeah.
So I will skip all these slides for the sake of time to save the time. Jumping to the case which I have faced during when I received a female patient, 80 years old, with a previous surgery in her right eye, phacoemulsification surgery 6 years ago, and nowadays. On that day, she came again seeking for a phacoemulsification in the other eye, but the difference of cataracts was horrible. The cataract was black, almost black cataract, with very dim red reflex on the microscope. I started with the phacoemulsification as I promised my patient to start with phacoemulsification, but I have the responsibility to decide another option intraoperatively if I found there's something related to the zonules or the density or the cornea intraoperatively. So when I started doing my phacoemulsification, I used to do all incisions with the keratome, as you see now, and then viscoelastic, and without stain, even with this dim reflex, I could fashion my complete capsulorhexis. And I was passionate when I saw this red reflex that I could groove and emulsify this hard rocky cataract. But actually, when I started hydrosection, I found that it's a bulk. It's a complete bulk. There is no separation between the cortex, the epinucleus, or the other parts of the nucleus. I started now to do my groove. The first step to divide this hard nucleus, to do a perfect and deep groove, or even to catch the nucleus and trying to help myself using the vertical chopping. I'm using the special chopper made by my dear friend, Dr. Prasad, which is fashioned especially for such cases. I tried many times to grasp this nucleus, to find a way to get a vertical chopping. I tried many times, really, using the maximal torsional power. The machine was an infinity machine, but I realized after many trials that this case was a need for this driller, not the Phaco Pro. So I took the decision very, very fast to change my mind and shift to manual small incision, not to extracapsular cataract extraction, to save the cornea without astigmatism and save the ocular tissues as well. I left the all incisions of the cornea as such, without any hydration or any stitches. Really, the fears was related to the zonular dialysis, which I found. I felt that the bag is not stable, so I was afraid of the more subluxation with dropping of this nucleus during the manipulation, and at the same time, I thought about the technique which will serve this big nucleus to be out of the eye without harming the bag, and at the same time, sutureless technique to avoid all other complications which may face if I convert it to extracapsular. The situation helped me really on that time. I tried to deliver this big nucleus from the small rhexis, and it was successful to deliver it in the anterior chamber. Then I used to cover the nucleus up and down with the viscoelastic to keep the cornea and to keep the bag and the posterior capsule away. Then my preferred technique, the sandwich technique. Actually, the nucleus is out now, and I checked the posterior capsule in the center. In the center, it's intact. Then visco expression for the remaining parts. Then in implantation of the PMMA, because I have a wide incision, so there's no need for the foldable IAL in such case because both of them are unifocal. So I tried to inside of the bag to keep it stable, and all the time the posterior capsule was intact. But I found that there is angulation. There is angulation of the iris. So I was thinking about either please unmute. Either a vitreous band from a general dehiscence or just a band from the iris tissue, angulating the iris. But anyway, I prefer to do anterior vitrectomy using this occlutome to clear the anterior chamber from any bands could be in the anterior chamber to avoid detraction. Finally, the anterior chamber is very clear, stable, the cornea as well, and the anterior chamber is well formed with this lovely air bubble, and my case ended in peace with the injection of subconjunctival dexamethasone with gramycin to cover the wound. And the surprise that this patient 2 days postoperatively came to me very happy with this crystal clear cornea and the completely covered wound and healed wound with this refraction, just minus 1.5 cylinder on this axis with unaided visual active 612 and best corrected visual active 626. And thank you so much. So the home message is the manual small incision technique, if I have to learn it as a phacosurgeon, because it will save me in such a difficult situation. And thank you so much. Yes, sir.
You have to stop sharing, Dr.
This record should be muted.
It was a really very nice presentation from Dr. Hosam, and thank you for joining us here in this beautiful evening.
Thank you, sir.
Really, we always look forward for your great videos, and you have really shown a very, very good video today, and we are really enriched with that. Some disturbance is coming.
And a fantastic post-op result also, sir.
Yeah, fantastic post-op result.
Yeah.
Just 1 point.
Thank you.
Clear cornea.
Thank you very much, Dr. Rajendra. It's really my always pleasure and happiness to be with you, learning from you and all the great surgeons in India. I'm learning all the time from your expertises.
And Dr. Hosam, see the net has holded.
Yeah.
He was a little concerned. He'd been blinking on and off, and he said,
Thank you so
pray
much.
for me, my net should hold. So the net has held.
Thank you for inviting me today to be always among this great forms. Okay.
Yeah, it was great to have you
here.
Yeah, Dr. Hosam, you very rightly showed that it is.
If I have any question.
Yeah. What were you?
Dr. Jasmine.
What is more important? Yeah. Can I just make a comment? You very rightly showed that what is more important is the visual recovery for the patient. It is not essential that you go ahead and when you find that the cataract is very hard, you are not able to deal with it, like you tried central chopping 2-3 times, but once you are not able to chop it, you took a right decision in converting to SICS and you gave the patient good visual recovery. I think what is more important is the patient's welfare rather than the surgeon's ego.
I think that is the take-home message there, that your ego should not become too big.
True.
Yeah. At any point in time.
Right.
Okay. Thank you so much.
Thank you very much.
Thank you so much.
Sir, so the next speaker is Dr. Deepak Mangur. He is the real speaker of today's webinar because Dr. Deepak is specialized in complex cataract surgeries. A lot of awardees to his credit, like Young Ophthalmology Award, APOS 2018, Best Paper of Session, APACR 2014, MM Joshi Overall Best Paper Award 2009, Best Video Glaucoma, Society of India in 2010.
And so he runs a very popular
YouTuber. He is committed to sharing and teaching surgery skills through his website. And I have also witnessed his number of good cases, very complex cataract cases come out with the best result. I invite Dr. Deepak to kindly present his deliberations. Dr. Deepak, please.
Thank you, sir. Thank you for the opportunity. Thank you, Dr. Rajendra Prasad and the entire DOS team. So it's my pleasure to be here. I'd like to share a case, traumatic cataract, which was an absorbed cataract. These are some of the challenges which we face, and let me go through this case.
Hi, here is a 27-year-old man who had sustained a penetrating injury with a stick when he was 12 years old. Since then, the vision has been poor in that eye and subsequently has developed this white thing. This was a membranous calcified type of traumatic cataract. The anterior capsule looks to be open, and there is also a high likelihood that the posterior capsule is open too. Now, we have got certain challenges to deal with. Remove this membranous cataract and preserve enough capsular support to place the posterior capsule lens, and then hoping that the visual outcome and the cosmetic rehabilitation is good. So I'm ready with a single piece lens for the in the bag placement if there is an opportunity, multi-piece IOL-4 sulcus placement, and an iris claw lens for the worst case scenario. So my plan for the surgery is that first I'd like to delineate the anterior capsule and see what is the extent of tear, identify the posterior capsule and see whether it is torn, and then try to dissect out the lens matter which is stuck in between these two capsules and see if I can remove it without damaging or compromising the anterior and the posterior capsule. In the best case scenario, if I'm able to clear out all the lens matter, then it might be possible for me to place the lens in the bag itself, which looks to be slightly unlikely. Of course, I'm ready with my anti-vitrectomy unit. Let's see how things turn out. Anterior capsule is stained and the eye is pressurized with OVD. I'm consciously making a sclerocorneal incision in this patient. The reason being, if I need to use an iris claw lens, I can extend the scleral incision. The first goal now is to identify all the different structures. I want to know where the anterior capsule is, where's the posterior capsule, and what is the extent of the tear. I'm using a combination of visco and blunt dissection to identify these structures and simultaneously to create some space so that the lens matter can be maneuvered out. Since it wasn't so effective, I have switched on to a much more flatter device. This is an iris spatula which is very thin and flat, so that I can introduce under the capsule and sweep it across to deal with all the adhesions of the anterior capsule with the underlying lens matter. The hands are switched. I'm trying to do the same thing from the other quadrant. And I'm trying to dissect out the anterior capsule from the underlying lens matter. This area, the zonule, seems to be very weak as the bag is getting displaced. So another area of concern for me. At this point, I'm thinking that the posterior capsule was already open and these fibers could be just thickened vitreous fibers. I'm not sure. So I thought the posterior capsule is already open. Let me begin by doing vitrectomy. Before that, I would want to inject diluted triamcinolone acetate and then start using my vitrectomy cutter. It's mandatory for us to realize that whenever there is a suspicion of any vitreous bands or membranes in the antechamber, it is not worthwhile to continue dissection until we tackle with these fibers. The suspicious fibers are first dealt with, and then the cutter is then used to clear off the central area. And now we can see that the central area is clear and which is devoid of any posterior capsule. Now the real challenge now is to get the lens matter out of the eye without any of it dropping into the vitreous. With my iris repositor, I'm trying to disengage these thickened lens matter. I've changed the strategy. I'm trying to go in with my irrigation cannula and then try to mobilize this adherent lens matter into the pupillary axis where it can then be aspirated using the cutter. So again I go back to my iris repositor, and this time with the chamber being maintained by the irrigation coming through my left hand piece, I'm successful in mobilizing the lens matter away from the anterior and the posterior capsule towards the visual axis. So this chunk of lens matter is now free. The cutter is reintroduced into the eye and this lens matter is then consumed by the vitrector. The irrigation handpiece is again used to mobilize this calcified lens matter. It is coming in piecemeal and a small portion of it is being mobilized into the antechamber, which is then taken care of with the vitrector. So the strategy of levitating the lens matter out of the capsular fornices using the irrigation handpiece is working well. The lens matter is gently maneuvered out of the capsular fornixes through the visual axis into the antechamber. Then it's taken care by the vitrector. The capsular bag is looking significantly clean now. I'm using the cutter itself to enlarge the anterocapsular opening. I want this capsular margin to be big enough. It's not visible cosmetically. At the same time, it gives enough support for my intraocular lens which is being placed in the sulcus. Some of the remaining cortex is being aspirated by the vitrector. And this part of subincisional lens matter, I'm just trying to levitate it using the irrigation cannula. Fortunately, it just flows out into the antechamber. It is then expressed out through the sclerocorneal incision. The last bit of cortex and also the thickened lens matter is eventually taken care of. Now we're ready to implant the lens. Cohesive OVD is being used under the iris to create some space. The multi-piece lens is gently maneuvered into the eye. The distal haptic lands above the anterior capsule and gently the trailing haptic is guided in the ciliary sulcus under the iris and above the anterior capsule. Now before doing optic capture, I need to remove the OVD which has gone behind the capsule into the vitreous cavity. With the irrigation in my left hand and the cutter in my right hand, cutter is introduced under the lens and it goes below the level of the posterior capsule. Then I'm going to aspirate out all the OVD which is there. With the fluid coming in from the irrigation handpiece to my left hand, I'm using a Sensky hook just to tap the optic of the lens back posteriorly so that it gets engaged or locked in the anterocapsular opening. As the optic capture is being done, there's a small area of zonular dehiscence which is evident where the edge of the capsular bag is fluttering, but nevertheless it's a very small area. The rest of the capsular bag seems to be sturdy enough. The ovalization of the capsulotomy suggests that the optic capture is perfect and the lens looks to be very stable and well centered. Before closing, I would want to do a small peripheral iridectomy because this eye can have inflammation and I don't want any pupillary block to happen. Time to close. Before removing the irrigating handpiece, I'm just trying to hydrate the wounds. So these are the first day post-op pictures. The pressure was recorded to slightly on the higher side and you started with anti-glaucoma medications. By 1 week, the cornea is very clear. And these are the pre-op and post-op pictures in the single frame.
Thank you. Thank you for the opportunity. That was it, sir.
Nice presentation, Dr. Deepak. Really, the first presentation of the patient, what we have looking for that a patient given the history of trauma and the capsule, the lens look like this. I think it is very challenging work to take out the remaining cortical matter, which has totally changed their nature and is very stick to the capsule. Can you go in the first way, like you can use the cutter in the same way, and then you can remove the total cortical matter and the capsules, which was normally already gone off with that. Can we opt that part of using the vitreous cutter on first go rather than to separate it so vigorously, because that may increase the zonodialysis in these cases?
You mean to say, can we use the cutter itself?
Yes. So remove all this.
No, access is a problem because if we blindly go with the cutter, we may also end up chewing the anterior capsule. So if the anterior capsule support is what we require to place the lens inside. So if we blindly go inside and do with the cutter, we also will be sacrificing the overlying anterior capsule itself. So we may lose that support. So it is a Sommer ring. It is sequestered between the anterior capsule and the posterior capsule. The posterior capsule is already open. And we want to retain some anterior capsular rim so that the lens can be placed on. So if we go blindly and try to cut it with the cutter itself, we will also be at risk of damaging the anterior capsule. So we will not be able to retain that. So that's the reason why it has to be mobilized out. because we want to have at least some 5 millimeter of intercapsular support for the lens to be placed. That was the idea by which we did not go directly into it.
Very,
No,
very
actually-
well said, Dr. Megur. Actually, these Sommer rings, because they are a slightly thickened structure of the cortex and the epinucleus, and many times they are calcified also. So if you try to cut them with directly with the cutter, then you will not be able to draw them completely out of the phonics. So it's always better. What he did was, like, you have to just dislocate them from the phonics and try to bring them at the center, and then aspirate, then cut it. So that is the best way. And he, I think, did a very, very good job. The only one thing that what I do is, like, I come across some of these cases, and instead of spatula, I use the hook. So drawing them with the help of the hook becomes very easy. You can just hook them from the periphery and then slightly draw to the center. But the spatula worked very well in his hand, and I think it was very well managed case. Yeah.
Actually, my first reaction was that, why not the
post-op photos? Post-op photos were looking excellent and wonderful.
Fantastic results. So my first reaction was, why not do the posterior approach? So, like, why not a lensectomy and a posterior approach? So, so you answered it in one go itself, because we could have gone in with a posterior approach and scleral fixated, and that's it.
Yeah. So no, I think it was the right approach. He really preserved the anterior capsular rim so nicely so that it could be placed in the normal position. Yes, scleral fixation is always a possibility, but then why do something which is more complicated, it really has pseudophacodonoses and all that problems.
Yes, the results are much more predictable when we can keep a lens.
Ciliary sulcus is always
exactly. If you've managed to preserve the anatomy, but this is not, this is not everybody's cup of tea, actually.
No. I think there is only one doctor.
Very well done.
And
very well done.
This was unthinkable. A lot of us would.
If you can manage the case from the anterior approach as well as the sulcus fixated or the intracapsular fixation of the IOL, we should
always a preferred approach.
It is possible. If not possible, then only go for the posterior approach or the fixated IOL.
Sir, I wanted to know how do you use the hook to maneuver it? What hook you are using? You're referring to?
Yeah, I use a blunt hook and blunt.
The hook, in the sense, is a Kuglen hook or
Sinsky hook or which hook?
It's kind of Sinsky's hook, but not exactly Sinsky's hook. It's a blunt and round tip hook, so that when you go into the phonics, you can very easily hook them and bring it. Because I have a video, because I would have shown that video, but I'm not showing it today. That video where I draw these Schomring's rings very easily. You can bring them to the center and then aspirate or
maybe I'll try that, sir, sometime next time when I get
I'll show you that video.
Something like the lens dialer, Dr. Prasad?
Yes, sir.
Something like the lens dialer with that hook?
No.
Slightly modified.
Not lens dialer. It's a modified hook, because I have that hook with me.
Okay. We'll see it next time, sir.
Yeah.
So with your permission.
Yeah.
And now we have with us the president of the Delhi Ophthalmology Society, Dr. Rajendra Prasad, who is the director and senior consultant at RPI Institute Research and Training Center in New Delhi. He is an alumnus of the RP Center and has continuous research and innovations to his credit, along with dozens and dozens of publications. He was awarded the National Innovator Award for innovations like the terminal chop, the sewing needle microcapsulotomy, the Terminator wedge tool, hydrodissection in posterior polar cataracts, and the T-Soft. He has been the winner of several best video awards, including the American Society, the ISCRES, the best paper at IIRSI, ISCRES, and the IIRSI gold medal, the UPSOS, the UKSOS, the Equine gold medals. He's been a speaker at almost all the conferences and numerous paper presentations to his credit, along with instruction courses at the American, the European, the Asia Pacific, the AIOC, and the IIRSI. And Most importantly, he is the moving force behind this global web series, as well as the International Film Festival that the Delhi Ophthalmology Society has started. Ladies and gentlemen, today the world just wants to know what is his most difficult case. Over to you, sir, Dr. Prasad. Your
Thank you
most
very much.
difficult
Thank you,
mission.
Dr. Bali. Thank you very much for the nice introduction. And I'll just share my slide. Okay, can you see my presentation?
Yeah, we can see.
Yes, sir. Fantastic.
Visible.
Thank you very much. Thank you very much. Thank you, everyone. And thank you all of the people, those who have joined this webinar. And as Dr. Bali has said, this is a new concept. We started in the DOS now this time. And this is going to be a monthly webinar. Every month we'll be having one webinar and on a special situation with the different topics. Thank you very much. So today I'm going to talk about the cataract surgery in RK operated case, and in a series of the first episode, Rafting in the Rapids. This is a special situation actually. I'm going to show you. It's not a great about the surgery, but the situation is very great and very difficult. It was very difficult to manage the situation. So fixes for the post-RK refractive surprises and prophylaxis for the future eyes. So I'm going to share a 56-year-old female had undergone right eye 8 cuts and left eye 16 cuts RK surgery in 1994. Had a progressive hyperopic shift of plus 3.5 in the right eye and 2.75 in the left eye post-RK surgery. Developed cataract, and we undertook the cataract surgery with 25.5 diopter spare of the thickness 1 IOL implant, and presented with the refractive surprise of plus 3 diopter spare on the first post-op day. We took the central corneal power with the help of the IOL master, XL length, AC depth, and all these factors were taken from the IOL master and calculated the IOL power with the ACR's IOL calculator. And this refractive surprise of plus 3 diopter spare with after implantation of 25.5 diopter. So ideally it should have been around 30 diopter spare. It was very challenging. We took the case for the IOL exchange, and doing an IOL exchange in an RK operated case is not so easy. So we did, this was the Pentacam report for the surgery, and EKR value was 32.2, which actually was much less than the IOL master value. We did the IOL calculation with the help of ASCRS IOL calculator, and the ASCRS IOL calculator gave us the 28 diopter. Started with the main incision. Since it was 8 cuts, so we didn't have much problem in making the main incision. And so this is how you have to take out the IOL from the, I call it as a hook and flip technique. Just hook one of the haptics and put it over the iris, and then take the another haptic out of the capsular bag and put it over the iris. And one of the hook is withdrawn, taken out, and hold this hook and then cut the IOL. So this is very important, because if you hold the hook, then the IOL is not going to flip. Otherwise, the flip may damage the endothelial surface of the cornea. So this is how you cut the IOL up to the mid, and then with the help of dial technique, like we call it pull and dial, pull the IOL with the haptic and keep dialing it. This is how you dialed it out of the capsular bag and out of the anterior chamber now. This was the IOL, and then went ahead with the IOL implantation into the bag. So this was a 28 diopter Technis 1 IOL kept into the capsular bag, and the wounds were sealed with the hydration technique, and it was absolutely watertight, so we didn't have any problem with the chamber loss. So this is how you can see, but with our surprise, the refraction was plus 1.25 diopter spare on the first post-op week. The reasons could have been the undercorrection, the overestimation of the central corneal power with the help of, and the IOL power, instead of 28 diopter should have been around 30 diopter. The biggest challenge was now operating the second eye, which had undergone 16 cuts RK surgery. You can see this is the patient where there are 16 cuts on the cornea. And getting the right central corneal power was the biggest challenge in this particular case, because looking at the history of the previous eye, so we did the tomography and took out the central, but as you can see here, the central corneal power was higher than the IL master, what the IL master gave the reading. It was 34.14, but the IL master gave around 33.5. And these parameters were entered with the ASCRS. ASCRS IL calculator gave 29.4 diopter sphere of IL. We did it with the Barrett True K for the prior RK with the partial history technique, which gave around 30 diopter. But looking at the history, previous history, I did the manipulation in the IL power, and with the addition of 1.75 diopter of the IL, we made it to 31.50 diopter of the IL was planned to put in the IL. Now, in this particular case, the surgical challenge was making the incisions, because of the multiple RK incision. So we have very minimal space to go inside. The side port was fairly possible to do, but for the main incision, I planned to do the posterior limbal incision instead of the scleral tunnel. So this was the posterior limbal incision made a little behind the limbus, and still went in between the intersection to make the main port. And you can see the main port has not disturbed the RK incision at all, and was able to make 2.8 millimeter of the incision. And this is how the rexes went. And the cataract was quite hard in this case, so I'm doing the segmentation of the nucleus, but you can see the iris, floppy iris. So because these high myopic eyes would definitely have some amount of the floppiness, so you could see the sudden meiosis of the pupil also. So it was getting quite difficult to remove the lens material, but somehow I could remove the nucleus and injected phenocane to dilate the pupil, and then completed the rest of the lens material removal from the capsular bag. But you could see the iris prolapse. So this could happen because of the posterior scleral incision, and but I could manage it by pushing it in and injecting the visco, and then implanted the IL of 31.5 diopter sphere in the bag. So the IL went into the bag and the visco was removed. But on the right side, you can see a little bit of dehiscence had taken place in the side port incision. But on completion of the surgery, this dehiscence was also closed with the hydration itself. I didn't need to do any suturing of this wound, and the anterior chamber was airtight, watertight, and well closed wounds. On the first post-op day, the refraction was minus 0.5 diopter with minus 0.5 diopter 85 degree with BCD of 2020. So to conclude, the patients with prior RK is really difficult in achieving the post-cataract surgery target refraction. The ASCRS calculator, Barrett True, Barrett's, all the Barrett technique and Haigis L formulas are the preferred choices. They give the more accurate result. And always aim for the myopic refraction between -1 to -1.5 diopter to minimize the post-operative hyperopia. So I added plus 1.5 diopter to the actual power which was detected by the calculator, and that gave us the actual target refraction of minus 0.5 diopter in the second eye. So this was the situation I wanted to present. Actually,
fantastic presentation, sir.
This was actually
sir, actually
the situation, because the surgery was not very difficult, because definitely because removing the IOL from the RK operated case is not so easy, but in this particular case, I could manage it very easily without hampering any the tissues and the RK incision and the capsular bag, and very nicely I could put the IOL into the bag. But the situation I wanted to present here was like what the RK in a RK operated cases, what IL calculation formula we should use, and how to get the targeted fraction. So I think no better than Dr. Coker for this topic, and because I've seen his many talks on the IL calculation formulas, and especially in post-refractive cases. So he's the best person to highlight the certain points on IL calculation post RK cases.
Good. Thanks. That's why you kept the last guy, the pinch hitter in the end. That's good.
I wanted you there.
Okay. So that was beautifully operated. The 2-3 things which we worked about 40-50 patients, and we published in AJO. The 3-4 things which you have to be very careful about. First, when one is the IOL power calculation, what we do is whatever you said is right. And on the table per se, we have an aura, which is attached to the microscope, under the microscope, and it picks up the lower order abrasions, something like the sphericals and the cylinders. And up till 16 incisions, it works wonderfully well. So whatever you get there after the cataract has been removed, you can actually pick up the data and do it. Our aim is to make sure the patient doesn't become hyperopic, because what is happening is after the RK, the central cornea goes so flat that all the machines which are picking up, it's beyond their range. So that's the end of the range it picks up, and it's further gone flatter. So there's a dictum we used to follow about 20 years back, that if you have more than 16 incision, you take the flattest A and make it flatter by 25% more. And that was coming as much emmetropic as possible. But that was a wild goose chase. It wasn't a very scientific thing, but we realized that it works wonderfully well. But this aura thing, which I started using now for the last 4 years, I'm using, and we've done about 3 theses on that. We realized that it works wonderfully well for the post-operated eyes, so that you don't actually need to have the pre-case and post-case and double K method and all those stuff. Second thing is that if you're doing the wound from the sclera, the iris tends to come out. So what you can do is you can go to the cornea. So the basic concept is 2 pi r. The circumference of the cornea is 2 pi r. So r being the radius of curvature, which is 6 millimeter. So 2 into 3.14 into 6 is what is the radius, and the number of incision you can divide it by that. So if there are 8 incisions, you actually have about 3 millimeters in between, and you can easily go between the incisions without a problem. So 2 pi r, what was taught to us in the school, works wonderfully well. But if it's more than that, then of course one incision will open up. So what we do is we go corneal only, but we make a transverse suture and we do it. I have lots of videos of that. I was not showing that, but in case you want, I can show that. And second thing which you did is that when there's a fluctuation of the chamber, because these are myopic eyes and you'll always have this breathing pupil which is coming. So it's always best to keep a cannula full of viscoelastic, and other side port, the resident who's assisting you, you tell him to keep putting the viscoelastic in between so that the chamber doesn't collapse, because you can't avoid that, because the cornea is thin. With the incision of the cornea, arcade becomes further deep in the center, and it actually goes like a trampoline going all the way up and down. The fluid goes in, it opens up and comes back. So to avoid that, you should reduce the height of the bottle. It should be low flow phaco in these ones, and you hardly need energy in these ones. So you have to actually manage with the fluidex in these patients. And once the central part is gone, best is to go with a bimanual. So you can actually hold the iris with one hand and go with the other one. I think you did this wonderfully well. And the iris prolapse can happen in these ones because these are highly myopic eyes. It does happen with best of the hands.
RP, it's a wonderfully operated case, and you're a master craftsman in cataract surgery. So there's no doubt about that. But one point about the post-RK IOL power calculation. Okay, can I?
Yeah, yes.
Go ahead.
Please carry on.
Okay. So the basic thing is to calculate the IOL power was to measure the central 2.53 millimeter of the cornea. Yeah. And the best tool to measure this in my own hands is the using the Pentacam HR, which gives you anterior posterior curvature both. Though anterior posterior curvature relationship remains the same in RK as compared to LASIK, where it has changed drastically. So in that cases where there is a LASIK operated case, I want to use a double K formula. But if it is not, it's a RK case, then probably the best thing to use Pentacam for the IOL, for the central keratometry, and then after that everything, falls in place. But still, in all these cases, I add one diopter to the power of the IOL as a thing, and because I want them to be on the myopic side rather than being on the hyperopic side.
Yeah.
So in my hands, I might have done more than 500 of my own RK operated cases, which I did almost 30 years back. So I found that initially there was always a hyperopia which was creeping in, but later on, once I got the hands on my pentacam, after that this problem is much less by a little bit of overcorrection in the IOL power. So that's the best, and use Barrett formula.
Universal.
Barrett,
Yeah. Barrett,
Barrett 2K.
Dr.
So
Prasad.
is there some sort of a diurnal variation to the K readings also? Because there have been reports that post RK, you're looking at diurnal variations.
Correct. That
how do you factor those in?
variation, Jitendra, will continue to be there even after you've operated. So there is nothing to, kind of calculation being done on a particular time that could be more accurate. I think the whatever time you do, the diurnal variation will continue to have, a change in the K reading a little bit, but not hugely. Yeah. So Sudarshan wants to say something.
Yeah, what Dr. Bharti is saying absolutely right, because there was a PERC study, which was a prospective study for the radial keratopathy follow-up, in which they found that if you're going too deeper, more than 90% and almost cutting and making PIs, actually they were cutting the iris also, PIs along with that. In those patients, the central part is fluctuating, maximum for the first 6 months, and afterwards, once the scars became a little more fibrous, it stabilized. So these patients actually were done around 10, 20, 30 years back, as Dr. Bharti is rightly saying. So there's not too much of fluctuation as such. So you can pick up that any time of the day, it's not going to change much. A 0.25 it won't make a difference, because as such, with so many incisions, once the eye dries up, the indentations take over, the cornea tear film breaks. So it's not a stable cornea. So you have to look at the stability of the tear film before you operate these patients. That's more important in these patients. And all of them will have Hudson Stanley line going across the incision right in the center. So you don't expect the vision to be 6.5. Majority of the time, the incisions are there. They cross over with the Hudson Stanley line. If you look at the slit lamp, this pigmentation crossover, the patient has to see through that in majority of the ones, and especially if they're more than 32 incisions. I've seen patients with 32 incisions. I don't know how many incisions they can make in the cornea. But I'm glad that the surgery is over and gone behind, but the patients are still coming to us. Yeah, and we have to be, looking into the surgeries.
What is very important?
Wants to come in.
What is very important is to look for the zone in all these cases. That is very important, because you have to see that how centrally the incision has extended. Because why I wanted to present this case was basically, if you look at the right eye, in right eye, the EKR value was less than the IOL master values. But in the left eye, EKR was more than the IOL master value.
That is what I was observing.
That makes so much of confusion, actually, because what we should take the central corneal power. So
I think we're looking at Kane and Carmona very, very expectantly. Hosam, I think, wants to make some point.
I'd like first to thank you for this case, which is full of difficulties and very well managed. Thank you so much. I had a case such this case post-RK, but my case was with some regular surface with high cylindrical error. So I went first to regularize the surface by the customized PRK. I did first customized PRK to regularize the surface to decrease the difference between the key readings, because of the post-RK. The post-RK changes in the surface is not as expected, because of the different power, the different tension in everywhere in all meridians of the cornea, will produce a part should be or could be flattened, and another part could be steepened. So the surface was irregular in such case. So if I plan for a cataract surgery on this irregular surface, definitely I will get a residual error of astigmatism or a spherical error. So I went first to regularize the surface by the customized topo-guided PRK. Then I went for the phaco surgery. The second point here, which I believe in, that the corneal incision should be, it's better to be avoided in such a case. A scleral tunnel approach is a magnificent way to enter the anterior chamber, because the response of the cornea is not
Thank
known.
you. Thank you, Dr. Hussain. Thank you. Actually, we are
One
short of time, sir. We'll take up the last talk and then we'll discuss.
Then,
Last talk.
yeah, I think we'll discuss after that.
Yeah,
Okay.
after that, yeah, we'll discuss.
Can you see my slides?
Yes, sir. Sorry,
Yes, sir.
So we need
sir, I would like to
introduce
introduce
you first,
you. Yeah, Dr. Sudarshan Khokar. He's an expert of pediatric cataract surgery. That is a great affinity of Dr. Sudarshan Khokar for pediatric patients. And except that, he also doing ICL, SMILE, LASIK. I mean, a lot of refractive surgeries. His expertise in pediatric cataract and complicated adult cataract as well. He conducted several institutional courses, instructional courses at various national and international conferences such as AAO, ECCRS, APAO, WOC, AAPOS, etc. So there is a long chain of it. He's authored over 80 index publications to his credit, and almost 20 chapters in textbook, including Atlas of Pediatric Cataracts. Dr. Khokar is a designer of Khokar capsular painting cannula and is also pioneered in the use of plasma blades. Thank you, Dr. Khokar, for such a great academic achievement. We would like to see you here, sir. Come, please give your deliberations here.
Should I share now?
Sir.
Perfect. So I thought I'll just add one extra thing, because I was planning to show you one case which was abandoned by somebody outside. The patient came to me for the other eye surgery. But since we're talking about the refractive, can you see my slides, please?
Yeah,
we can. Yes, so we can.
Okay. All right. So I'm going to put it on the slideshow, and there you go. So we've done lots of iris claws. I think I've seen people doing iris claws for refractive purpose. That was about 25, 30 years back, close to the RK era. So this is one of the patients which came to me. So this is my approach, which we published. I was scared to open this eye up and take the lens out in the first place, because if I take the claw out, the pupil is going to die on me. It's going to constrict, become 2-3 millimeters. It will become difficult for me to operate. The second was, if I enlarge the section and take out the lens, one, the pupil can go small. The second, the incision, even if I suture, will not allow me to do a good closed chamber phaco. So what I did, I'm going to just keep it a little small so that I can cover up 2 or 3 videos in this. So make stab incisions. We thought, let's go ahead, because if you notice, it's a very good enclavation. It was somebody who's done it and knew the enclavation should be about 1/3 of the claw. This was in fact half the claw which was enclaved. So we went inside, we did staining of the capsule. We put in the viscoat in the front and helon in the front and helon at the back. So this lens is sandwiched, it's still stuck to the claw, and claw is holding it so well. I did a gentle hydro there while the lens is still inside. And then this was the only time when I had a little problem, because the sleeve was trying to push my lens away, but it still did not disenclave. But now what I'm doing now is I don't put my sleeve inside. I use this step without my sleeve. So I use a phaconet here. And because the lens is there in the front, I keep putting viscoelastic and cold chill BSS on the needle. It doesn't burn. And you don't need much energy, because these are myopic cataracts and they're not very hard cataract. And then I went with the biomanual and with the coaxial and removed the cortex. So you notice what I've done is I've taken the cortex out and the lens is still entangled onto the iris. Then I fill my bag up. Okay. And then I enlarge the section and put my lens into the bag. So this surgery, at least I think, is about 10 years old. That's why we are still using the yellow lenses that time. And now you've got 2 lenses in the eye, one in the front, one at the back. Now I can easily, safely take this lens out. And once this lens is out, you remove it. See, the pupil is dying on you. Whatever you do, how much gently you want to remove this claw, it will always have a little problem, especially when the claw is there for 30 years. This is what happens. It always brings some tissue along with that, and there's always a pupil dying on you. So I enlarge the section to about a 5.2 now, because my cataract is already done, my lens is in the bag. And then I just float this lens and take it out, holding with the forceps, and that's about it. And you can always put a suture here and finish the surgery. I'll just go a little fast on this and finish it off. Okay, put a suture and this patient is good. hardly any cylinder in this one, and that's what it looks like at the end. And okay, now this is the second patient. She flew in all the way from Canada. Somebody in India did iris claw, and nobody was willing to take up this challenge there. So what we did, we thought, okay, let's take the lens out first. So what we did, we made 2 stab incisions on the side. So that's the way I put my iris claw. So I was always comfortable removing my claws from the side. So I put dispersive in the front and cohesive at the back, and then enlarge the section a bit. Enlarge the section for you to go and hold the lens firmly. The important trick here is to hold the lens firmly, and then you can go and disenclave using that needle, which comes from the same company, Optic. So I come for the other side now, hold it, go, hold it, and it's almost like a clear lens extraction here. And come from the side. You see, when I come from the side, my needle actually comes right on the thing. So if I make my incision on the side along with that, I will not be able to disenclave as well, because that's too close to the incision. So then I rotate this lens and I take it out. And once this lens comes out, you can just go ahead and do a phacoemulsification in this patient as usual. I think I'm not going to show that because everybody is a great surgeon here. So the take-home message on this first talk is that it's a pupil constricts after IOL removal. We all know that. So the last incision will make it unstable. You always proceed the surgery after making sutures, putting suture. And if you're putting the lens inside and still doing the surgery, without removing the phakic lens, you can use a phaconet without putting a sleeve so that your lens doesn't get pushed in. And we worked this technique for at least 30 patients by now, and all have done very well, and we didn't have any complications. So that's one. And I think this was the other patient I'll be discussing. This patient was done 3 months back, and the paper, as usual, did not reveal anything. They said there was a complication on the table, the surgery was abandoned. This guy actually came for the other eye surgery, and my resident told the other eye, we always have to look at both the eyes. So we said, what happened to this eye? He said the doctor said the eye has gone bad and they couldn't do anything. They refunded our money. And they said we didn't enter the eye, but because of the block, expulsive happened, and we had to send you back. So he came to us. So we saw there were 2 sutures, not 3 up superiorly. There were lots of fluffy cortex. The other eye consensual reflex was very good. So that gave me a clue that the optic nerve is still functioning pretty good in this patient. UBM showed an intact posterior capsule. So we took up this challenge to open the Pandora's box. I hope everybody knows who was Pandora. Pandora was a lady who used to put everything into a box. And when you used to open the box, she herself didn't know what is lying where. So I think a gentleman from the Egypt can tell us better about Pandora's box. So this, you saw the UBM. I'll just go back again. The UBM is important here because if you see the UBM, I'll stop it here. UBM is opening in the front, the fluffy matter, and that's what you can see all the way back. The posterior capsule is distended. If there was an opening, this lens matter would have fallen back. So we do UBM in most of our patients who are complicated cataracts. So this one actually helped me a big way. So I'll show you the video and a quick surgery. I think this is a 3-minute shortened video. So you see there are 2 sutures there, 3 sutures rather, and I make a stab incision there and stab incision here. It looks as this is a rexis margin, and they did attempt a surgery, which they didn't tell the patient. So once I make, my first thing is to put in a dye, because dye is not going to stay in the cortex, it will stay in my capsule. So that basic concept I'm using here, and I'm just putting it there. Then I realized it was a very small pupil. The rexis, and they eaten up the iris. So maybe they did the surgery from the superior part. We saw all the complicated cases today managed so well, but this surgeon maybe was not as dexterous in surgery, and there was an iris prolapse. So maybe he chopped the iris off superiorly here and put the sutures and left whatever was intact, but he did attempt phaco. So first, that's what I said. I extended this rexis because anything which I was doing with a small fibrous margin would have been more prudent and causing more complications. This one, I didn't want that. I didn't want anything to happen with the endothelium because he is already struggled and this pressures are high, which was brought down by the anti-glaucoma medication. So once I extended the rexis a bit, then I went in with my phaco, usual 2.2 incision, and I started eating the cortex with the suction phaco, and now it's basically very minimal phaco I'm using. I usually use 20 to 60, and that's my ozone. I don't use any longitudinal phaco in these patients, and that started coming to me, and it was almost ready, fluffed up lens material. This patient was 60 years of age. Surprisingly, the lens wasn't that hard, so I could manage it very easily. And once this is gone, we again checked the posterior capsule. It was intact. And every time I was coming out, I was putting viscoelastic and viscoat also in this patient so that the endothelium stays healthy. And once I did my aspiration of the cortex. See, the cortex also is so fluffed up, and it's like a denatured egg, like a boiled egg, rather than a proteinous thing which flows. So this one you could eat up, and the posterior capsule is intact. And since Parex's size was good, everything was good at the back, and the pupillary reactions were good in afferent in the other eye. In this one, you couldn't see because you could hardly see anything, and hardly any pupil there superiorly. So we didn't do anything for the superior pupil. We didn't put any implant in this one, as Dr. Bharti did, because this patient was a poor patient, and we just put an implant in this one in the back. And this patient, the next day, had a 6/12 vision, and he was very happy. And then we operated the other eye, which went uneventful. So the take-home message here is that maybe there was expulsive, but the expulsive would have happened. So you have to be ready with the expulsive. It can happen with anybody. I'm not blaming the surgeon per se, because surgeon did the best possible, and he even returned the money also to the patient. So what can happen, you should always be ready, especially for the expulsive, because expulsive can happen to anybody. So you take a good history, as I think Dr. Mahipal has insisted earlier. All these patients, the history has to be taken properly. If they are hypertensive on medication, regular medication, or they're not taking medication, you have to look into that. If you can measure the corneal thickness, and in case these patients have any other problems, as weak sclera or a nanophthalmos kind of eye, those are more prone for expulsive. So once this was done, we realized that we helped this patient get some vision in this eye as well. So with that, I'll stop both my complicated, and I'm scared of all the cases. I'm a very, scared surgeon. I take all the cases as difficult cases. So all my cases are difficult for me till it's done and they're out of the OT. Thank you.
Great. Thank you, Dr.
What was expected from Dr. Khokar?
all difficult cases managed so easily.
Sir, how many deep breaths do we take after this?
Yeah, I think 4 should be good. No, I wanted to put the second case, but since we are discussing about the RK and post-RK, so I thought I'll put this one also, because I have a set of patients in which the patient had got RK done earlier, came to me, and we put ICL in these stable patients, and now they develop cataract. So you have to remove the cataract in the patient with the RK and an ICL in the eye, and then put a cataract. So I didn't have time, otherwise I would have shown off.
Khokar have done a great job.
Amazing.
Just want to make
some question.
I'm learning from Tityal only always. I'm following his footsteps.
A few comments.
Yeah, sure. Yeah.
One, the second case, I feel it may not have been expulsive, because rexes are so small. It was basically the rexes block, which had led into a high pressure, and surgeon would have panicked at that situation. And the post-phakic, very sized lens, we have also done some cases. We do a femtosecond flex in those cases, which gives a nice capsulotomy and nuclear fragmentation. Then you can complete the surgery effectively. So maybe sometime if people have an option of flex, they can use that as a option in a phakic IOL situation also. Otherwise, your surgery was done wonderfully well.
See what I was trying to
and
show
it was so nicely done. And just last comment on an RK patient, because it was such a long discussion on RK patient. I think only one comment. We do a assessment of cornea by 2-3 instrumentation, and IOL power calculation by 2-3 formulas. The only concept is take the lowest possible reading for a keratometry and go to highest power calculation amongst all the formulas. So you might get into a nice way. And nowadays we all understand if you have Barrett with you, that should be the choice. Otherwise, Haigis also does very well in RK patients. I think that is the right understanding for these cases. Otherwise, most of the discussion was really good.
Yeah. No, I just wanted to show I wanted to show the techniques, not a technology. Technology you can buy from the market. You can buy a femto, you can buy all these funny stuff, plasma blades. But if you can develop your technique, which is what I was trying to share, that all these patients, a simple UBM actually tells you so many things at the back, and you can go ahead and do the surgery. Yeah, please go ahead.
One comment. Excuse me. One comment on IOL power after RK and the correction of residual power. I think in whatever way you do, the best thing is to take the IOL in the eye, and then at a later point in time to correct the whatever error is there with the PRK, and not before, because RK incision will always be disturbed, and the power which comes later on will not be accurate. So it's after 3 to 6 months down the line that you do a PRK, rather than doing smoothing the cornea before and then.
Well, Dr. Bharti, sometimes, these people do have a hyperopic corrections.
Correct.
And doing a PRK in these cases can be really tough in a very compromised cornea.
No, doctor.
And nowadays, all RK patients, we do eye trace for all of them. And show the patient that your cornea is totally aberrated, because some patients are not happy with the visual outcome.
Right.
So it is a nice way to show them it is not the cataract surgery which has led a poor vision. It is your cornea which is not good.
That is why I'm saying you overcorrect, make it myopic, and then do. And the second thing, important thing is, I have had some patients coming from other centers after RK, IOL, and then pinpoint pupilloplasty. And in pinpoint pupilloplasty, they are having trouble because the center of the pupil is not right in the center of the cornea. It's somewhere else, whereas it is causing more distortion, and their vision dropped after the pinpoint pupilloplasty. So those things are very.
What will happen to these high myopic patients if they develop some posterior segment problems? Who will handle that?
That's another fact. But people are still doing pinpoint pupilloplasty for that, and vision gets worse than 636, which was 618 after the IOL implantation. So those things are very pertinent and should be kept in mind.
Yeah,
I think when you do the PRKs after RK, it's not a simple thing, as Dr. Titial is telling you. That's very good. That's very important. The second thing is that you have to make them myope only. So if it's a myope, you can still do a correction. And operating on a prolate cornea versus an oblate cornea is a different ballgame altogether.
Yeah,
when you do on a myopic eye in the center, you can actually do whatever for PRK. But the same thing will not hold true when you're too close to the periphery with all the vessels coming, and especially with the incisions, all these Hudson-Starley line, which are giving more blood flow to the periphery cornea, they all will go into regression overnight.
And also, very quickly, you must keep in mind the fact that you have MMC. The experience earlier was without MMC, PRK without MMC. Now, since you have MMC, the issues are much better addressed. That's what I am doing.
Dr. Bharti, with RK eyes are not common normal cornea on the surface. They will still have a problem because you got the grooves, you got the direction for the growth of the cells.
That is why I say that after doing the cataract, you let it settle for about 6 months before correcting. Don't be in a hurry, and definitely not prior to cataract surgery, because it can go wrong in any manner.
Put a BCR on the top, get over with it. Don't touch the cornea. Is my take on
I
this
think
one. I will
looking
not
at
touch these corneas.
Today's discussion, the best case presentation was RK only.
The moment you come in, the cornea has to come in.
Has to come in.
So even the fake
if you and Dr. Bharti are there, cornea is always going to be there.
Cornea, RK
in the center of it.
We can't debate with Dr. Bharti.
In the center of it,
grand, father of RK.
He says he created his own patients. He says for the cataract later on. So that's good. In-house, you can churn out your patient in the RKs. No, we have certain cataract surgeons also. They get their own patients for DSAC and DMAC. So I mean that's okay. In-house production of the patients,
Sir, complete range of treatment.
So, cradle to grave.
So what I was trying to say, that if you get a patient who's abandoned by other person and the patient is willing and the other eye is showing you a good pupillary reaction, don't just call these off. And the sutures also not buried. In fact, the sutures are getting, it was getting decolored because it was rubbing against the patient having pain in the eye. So I just thought, what's wrong with this? He said, "Wo to khatam ho gaya aankh." I said, "Let me have a look." And then I saw. I said, "If you mind if I operate this one first?" So he was actually shocked. But he has 612 vision on the first day with this kind of thing. I mean, I think panic when it strikes you, any case can become difficult for you. The going gets tough, but the tough should get going when the going gets tough. But it's easier said than done.
That's not how it works. That's not how it works.
In the center, we've seen all the residents. So I'm happy because any problem, they call me. So I know I get into a situation which I haven't created, but I get experience from that. So I owe it to my residents also. And most of them are very good surgeons, but any surgeon can have a bad day. So especially this patient was actually, he came from Rajasthan, actually, I shouldn't be talking about. But then he was not even told properly what happened. And Dr. Titial rightly said it could have been expulsive. What I thought was when the probe went in, the pupil constricted and he didn't maintain the chamber properly, and he ate the RS after making the rhexis, and then he realized suddenly that fluid has started going back and it's like a problem. But the bag was distended. You saw the bag was so distended in this one on the UPM. Yeah. But luckily the posterior capsule was intact. So
yeah,
he was lucky and I was lucky.
Sort of a capsular block syndrome.
Exactly.
Yeah, it looked like that, sir.
Right.
I think Dr. Tityal very right. What I feel in RK cases is what is very important is to look for the size of the optical zone and the centralization of the optical zone, because many times you see the center of the optical zone is eccentric. It's not exactly in the center. And then we are taking the K readings with the IL master or any other device. It would give you a lot of variation if it is not in the center. And you try to look at the center and your center is away from the center. So that is very, very important. That is what I have seen in these two cases, actually, two eyes. Because of the central, there was a problem in calculating the K-power. So I think now this is the end of the webinar, and I really thank you all and all the faculty, the great faculty, Dr. Tityal, Dr. Bharti, Dr. Mahipal, and all of you. So really, it was, you made the session very thrilling and enriching with academic part of the session. And thank you very much, and all the audience also. Thank you very much for joining us.
Take a snapshot.
Take
a snapshot.
Bageshwar, please take a snapshot of everyone who's present.
I've taken already.
It's okay.
I think it was
next time. Next
yeah, Dr. Banati
will be on glaucoma, and Dr. Balla is going to.
वैसे आपने वो Ethan Hunt वाला तो आपने दिखाया कि पोजीशन वो जैसे वन में.
Can we have a comment from Dr. Banati also? She's also there.
You can do glaucoma better than Dr. Bhalla. I think Bhalla is a good glaucoma person. I know.
Dr. you want to say something?
May I do cataract also, sir?
I think it has very comprehensive coverage of the entire gamut of difficulties in cataract surgery, a wonderful symposium, and I think I'm privileged to listen to all the stalwarts in cataract surgery. Thank you so much for so much learning.
I think it is really fantastic to have
joining us this evening, and you are always with us, and we feel you are here with us, and we feel like our brother is here. Thank you very much. Thank you, Dr. Hussain.
And fellowship and dinner is outside.
Yeah, outside.
Have your own food.
at 9:30.
Have your own food. You know.
Now all the fellowships and dinners are at DOS office. So
Dr. Prasad will do better than that. Such a good webinar. I think with all the stalwarts, as Dr. mentioned, all the stars of cataract surgery from across the country, and such difficult cases, I think illuminating for us ordinary souls, and difficult cases handled with such great expertise. I think this is the way. And one thing, Dr. Kokar, was once panic sets in, I think you really lose your cool, and even the simple complication becomes a very difficult complication to handle. So just and do what you can do best. If you can't, then you refer to people who can really handle it, but don't mess up with the eye. So very difficult cases handled nicely. And as the title is very good, Rafting in the Rapids. I thank everyone, all the expert speakers, all the great surgeons, and the wonderful participants who have participated. Special for participating from Egypt, Dr. Tityal sir, Dr. Mahipal, Dr. Bharti, Dr. Kokar, everyone, and Dr. Rajendra Prasad, of course, for showcasing your wonderful skill in managing these difficult. Yes.
The next time we'll come up with a different question.
Bye. Thank you
so much, sir.
Bye, everyone.
Thank you.
Both the moderators for managing the session.
Yes. How can I forget our wonderful moderators, Dr. Jatinder Bali.
Dr. Bali is behind this whole scene, and he has really worked hard to.
Yeah, great. And Dr. O.P. Anand also for wonderfully managing and moderating the whole.
Thank you so much, sir.
Dr. Hussain, you want to say something? Yeah? You are.
It was fun. It was.
Okay.
It was a learning experience.
I'm just saying thank you so much for the wonderful session. Really, the surgeon is built by the experience how to deal with the difficult cases. The regular cases is not building the surgeon experience. Actually, the difficulties make a talented surgeon and a fully equipped surgeon for the difficult situation. Thank you for the wonderful session and cases, and also always my pleasure to be with all of you. Thank you so much. Bye bye.
Thank you, Dr. Hussain. Thank you very much.
Thank you.
Dr.
Good
Hussain.
night.
Good night.
Thank you.
Good night.
RP, it was better than the OPL, which people do it,
Actually, it was because of you, sir.
This was actually had a teaching and learning,
Yeah, definitely, sir. Definitely.
Sir,
And,
But it is but I can say, sir, one thing, that it is the beginning of the webinar, but we are thinking, and it is one of the best. So very good start that we are observing.
Actually, with Dr. Tetia's presence, we all shine. So that is
Yes,
that is
no doubt, no doubt, no doubt.
Wonderfully done. Wish you all the success.
Thank
And
you.
hope that we have a better and better shows.
Thank you so much, sir. Thank you so much.
Thank you very much.
Now, my friends, it's here 5